I get asked often, both with the WHO Commission on Social Determinants of Health and the English Review, known as the Marmot Review, what's the one thing you would say to politicians? I think one thing, my God, we made recommendations in the English Review. We had 6 areas of recommendations, 9 in the Global Commission. They want one thing, apart from reading my report. That's the one thing I'd recommend, reading the reports. The one thing I would say is to evaluate all policies for their likely impact on health equity, the fair distribution of health. So, for example, in Britain, as in all European countries, there is intense debate on economics. How are we going to respond to the global financial crisis, and particularly the European crisis? Sweden's doing better than Britain is in that response, but there's intense debate about the nature of the government's economic and fiscal response. I would say, make sure that you evaluate your policies to deal with economic problems in respect of the lives people are able to lead and the distribution of the key social determinants of health, and hence the likely impact on health equity. So, for example, if your economic changes are regressive, if they impact more on the poor than on the wealthy, other things being equal, that's likely to increase health inequalities. Well, that ought to be part of what a government should do in evaluating its policies. There's much that governments can then do specifically. In the Marmot Review, in the English Review, we had 6 domains of recommendations: early child development, education and lifelong learning, employment and working conditions, minimum income for healthy living. In other words, calculating the minimum different family types need to be able to lead a healthy life and ensure that everyone in society has the minimum income for healthy living. The 5th was healthy and sustainable places in which to live, and that includes housing, the nature of communities, and the broader environment, sustainable development. And the 6th was what I call a social determinants approach to prevention. In other words, trying to deal not just with smoking and drinking and diet and obesity, but the social causes of the patterns of smoking and drinking and diet and obesity. You notice I haven't mentioned the healthcare system. We of course want a healthcare system with equitable access, because when people get sick, everybody needs to know that there is a good healthcare system there. But it's not lack of healthcare that causes the problem in the first place. Well, I can talk more about Britain than I can about Sweden in terms of response to healthcare. What we know in Britain is poor people go to the doctor more frequently than wealthy people. Now, they have more illness, but their degree of attendance at their general practitioner in primary care is roughly proportional to the extra illness they have. So it actually isn't a problem, and that's because we've had a health system free at the point of use with equitable access, and it's been there for everybody. And one of the concerns with the changes to the National Health Service in Britain is that that may no longer be the case in the longer term. But as for now, the international comparisons show in Britain that cost has not been a barrier to healthcare, and there's very equitable access. Now, the content of what goes on in the encounter with the healthcare system very likely differs depending on your socioeconomic level. So the person with more education will discuss with the doctor what they should be doing, should they be changing their lifestyle, doing more on prevention, whereas the person with less education is more likely to be a passive recipient of what the doctor tells them to do. So they content of the encounter is important as well as the frequency of encounter. Always see light in the darkness. I've been going around the world saying I am an evidence-based optimist. If I may, let me come back to England. We have a centre-right coalition government in England. People said to me that the government will never take on your review, which was commissioned by a Labour government. Turned out not to be the case. The government issued a public health white paper. It said it was the government's response to my review. They said that reduction of health inequalities has to be at the centre of the government's public health strategy, and we will not solve this through the healthcare system. We have to take action on the wider determinants of health. Now, people have said to me, you need to look at what's going on in the rest of government policy. Yes, of course. So I'm not a cockeyed optimist. I'm a realistic optimist. But still, they took it on. And we've got a lot of traction from local government. The city, London, the Mayor of London has taken this on. London has a health inequality strategy. And we're working with a number of cities and local governments around England, Wales, Scotland, potentially in Ireland. And in England, these areas, these local areas with whom we're working, are preparing Marmot implementation plans. So I'm really encouraged, despite the cuts in funding in the public sector, despite the economic crisis, despite the regressive nature of the fiscal changes, we have local government working actively to say, how can we address your 6 domains of recommendations? I think that constitutes light at the end of the tunnel. We tried to look at that with my English review, and we said it's not enough just to look at costs of the intervention. You've got to look at the cost of doing nothing. We calculated that if everybody in society had a mortality as low as that of people with university education, because there's a social gradient in Sweden as there is in England, the lower the level of education, the higher the mortality. And if we could bring everybody's mortality down to the low level of that of people with university education, which in principle should be feasible, then every year for people aged over 30, there would be 202,000 fewer deaths each year. That's 40% of all the deaths that occur. Now, I did not want to put a pound or a euro or a dollar cost on the value of a human life, but were you not so finicky, were you inclined to do that, the cost, the life years lost, is absolutely enormous. Now, if you say, well, these are theoretical costs, well, okay, but there's cost to the NHS, which we calculated. There's lost taxation, lost productivity. There's real pounds that are coming off. So investing, and it's an investment, it should be seen as an investment, to reduce the social gradient in ill health will reap huge benefits in terms of improved health and loss of less spending on the NHS. But there'll be other benefits. And let me give you an example. You will have heard about the riots we had in London, starting in London last summer. They started in an area in the northeast of London called Tottenham. For some years now, I've been pointing out that the small area of London with the lowest male life expectancy is in Tottenham. What a coincidence that the riots began in the most unhealthy place in London. Now, I don't think that civil unrest causes ill health, and I don't think ill health causes civil unrest. But a study of 1,000 young people who were arrested in the summer riots showed that 91% of these young people, 91% were not in employment, education or training. Well, we know that not being in employment, education or training increases your risk of ill health. It also increases the risk of civil unrest. So here's another benefit. Invest in education and employment and training of young people. You'll get less civil unrest, better health, and a better educated workforce.